Let's take a couple of minutes today to talk about the BRASH syndrome. That stands for bradycardia, renal failure, AV nodal blocker, shock, and hyperkalemia. In patients with BRASH, you can see significant bradycardia even in the setting of therapeutic AV nodal blocker dosing and mild hyperkalemia due to the synergistic effects of those two things. The cascade that we see in BRASH syndrome is bradycardia, which results in hypoperfusion, resulting in renal failure, which in turn leads to hyperkalemia, which then leads to worsening bradycardia, worsening hypoperfusion, worsening renal failure, and worsening hyperkalemia, and you can see how this can cycle on itself. BRASH can be triggered by an insult to any part of that cascade: an increase in the AV nodal blocker dose, renal failure due to dehydration or infection, or addition of a potassium-sparing diuretic. Treatment starts with volume expansion if the patient is hypovolemic. Once the patient is euvolemic, you want to start diuresis to get some of that potassium out of the body, and if the patient has true renal failure, they might actually have to go for dialysis. Calcium can work to improve bradycardia, and if the patient is hypotensive, epinephrine is actually the vasoactive substance of choice because it both increases heart rate and shifts potassium into cells. The key is to consider this diagnosis in any patient with bradycardia on an AV nodal blocker where you see even mild hyperkalemia.